Thank you so much for inviting me for this seminar. I must say I'm so excited to be here, and looking at the numbers, I must confess that you are my largest audience so far. So hopefully you'll have a fun an hour or so. I must say I did find it difficult to pack a lot of things into the presentation. So there will be a point in the talk where I'll probably just check with you how you're doing to see if you want me to keep going or if you want me to stop. So as before, I really want interactive things. So if you have any questions during, please post them in and I'll try to do my best to answer them at the very end. So my name is Petra Hanson and I'm currently working as a clinical lecturer in diabetes and endocrinology. I'm based in Midlands at Warwick Medical School, and clinically I work at the University Hospital of Coventry. I have done some talks before for these companies. So what we will cover today, and it is going to be a jump-pack session, is I will go through an overview of diabetes and very much a wrap-up of the changes in management of type 1 and type 2. It will be very quick whistle-stop tour. I'll just go through some of the main bits. And then we'll really go into the main event of tonight, which is go through the emergencies. I have divided them into 6 different kind of case scenarios, and the things we will cover will be hypoglycemia, DKA, diabetic ketoacidosis, and a little subtype of DKA, which is euglycemic ketoacidosis. We'll talk about hyperosmolar hypoglycemic state, diabetic foot, and the last bit of the presentation is about what to do with hyperglycemia, which doesn't fit into any of these emergencies. So just to paint a little bit of a picture of what's happening worldwide with diabetes, we know for sure that the prevalence of diabetes is rising. So in 2014, it was about 8.5% of adults. It's gone to 10.5% 2 years ago, and it's projected that by 2045, which still will be a time when probably a lot of us will be working, the prevalence of diabetes will be 12.5%. In the UK, currently, about 1 in 15 of our adults live with diabetes. The biggest proportion of diabetes is the type 2 diabetes. And this really brings me into a quick overview into what different classification of diabetes we have. So as I said before, the majority of the current diabetes is type 2, by 90%. Type 2 diabetes happens for a lot of different reasons, but really the main characteristic is when an individual develops insulin resistance, and over time, pancreas starts failing, so there will be a progressive insulin deficiency too. Type 1 diabetes, which is much less common, is autoimmune destruction of the pancreas or the beta cells. And into that category, we also put in some of the latent, so late onset autoimmune, so the LADA type. Then we've got, again, a very much smaller proportion of diabetes, which could come for various reasons. One of them is something called MODY, so the monogenic diabetes, which runs very much in the families and have very specific treatment. For example, some of them respond really well to sulfonylureas. We have got diseases of the exocrine pancreas. So, for example, if someone has injury to the pancreas through pancreatitis over time and eventually develop failure of both the endocrine and exocrine function. And then the last subtype I wanted to mention is something that, again, is becoming a bit more common, which is gestational diabetes mellitus, which is diabetes that manifests itself in the 2nd and 3rd trimester of pregnancy, but goes away when the lady gives birth. But really importantly, with the GDM type, we know that over 10 years, 50% of women who have GDM will develop type 2 diabetes. So it's really important hallmark because we know that that subgroup of ladies will be very high risk in the future of developing type 2 diabetes. And I really wanted just to show one more slide about type 2 diabetes because that is particularly my research area and I'm interested in it. But the reason why it's really important is that people with type 2 diabetes have got significantly reduced life expectancy after 10 years. We know that over half of them will have microvascular complication within the 10 years of diagnosis. And given that a lot of them actually don't know that they have diabetes for ages and present at much later stages, they may actually present immediately with the complications. For example, the eye complication, retinopathy, or the renal disease, nephropathy. We also know they have a much higher risk of the macrovascular complications, so the heart attacks, strokes, and the hospitalizations of heart failure. So I think it's really important just to bring up to attention again that actually, even though tonight is about the emergencies of the diabetes that present very, very acutely, actually in the background is this, which is really, really important to address in the long term. So I promise that we'll go through a very quick update on management of type 2 and type 1. And I only really have 1 or 2 slides on this. And I think this is summarized very nicely through the American and European guidelines, which actually states that when someone develops type 2 diabetes, after the first line of treating them with a lifestyle medication and giving metformin, we should really be giving them one of the new drugs, so one of the two. And this is either a group of drug called SGLT2 inhibitor or a GLP-1 receptor analog. And this table shows nicely that the choice of the drug depends very much on the medical problems that the patient has. So whether they have got atherosclerotic cardiovascular disease, so the orange one, or if they have chronic kidney disease, the CKD, or if they have heart failure. And I found this really helpful because actually it changes a lot of what the previous approach was with treatment of type 2 diabetes. And the rationale for this change that happened 1 year ago was very much the impact of these neuromedication on the long-term effect of developing the disease of the chronic kidney disease and heart disease. And we know that they help very much so. So this is really important. And now it's happening. GPs are starting to prescribe the new medication. And just so you're aware of what some of the names of the new medications are, so the class of SGLT2 inhibitors, the commonly prescribed ones that we see are the ones ending with flozins, so dapagliflozin, empagliflozin, canagliflozin. Most of my patients can't pronounce it, so they just say dapa, empa, or cana, but these are the ones they are probably more likely to see in the clinical practice. The second newer type of medication, the GLP-1 analogs, are brilliant medication also, available either as injections or some of them now as a tablet too. The problem we have worldwide is actually we don't have a stock at the moment. So this is a problematic thing because no one can get it at the moment, but hopefully at some point next year, the stock will reappear. And some of the names to be aware of would be the older one, old-fashioned exenatide, some of the more common ones now, liraglutide, which comes as Victoza or Saxenda based on the dosage, and dulaglutide, which is once weekly, and really the newest one of the block for the GLP-1 is semaglutide or Ozempic. Now, not that long ago, about 2 weeks ago, a very new thing came to the UK, which is a new combination of the GLP-1 analog class with a GIP, which is gastric inhibitory polypeptide. And it's very exciting to us diabetes doctors because we know that it's even better than the GLP-1 analog, and we know that it helps patients with HbA1c reduction of the value we haven't seen before, and also really excitedly, it helps people lose significant amount of weight, and we're talking about above 10%, sometimes up to 25% of weight loss from body weight. So this is something that is very new. So again, you might see it popping up when you see patients in ED or when you pick an ambulance that they have this kind of medication. It's called Mounjaro at the moment, so keep an eye out for that. And then for the type 1 update, I think really it's about technology. So we have made some incredible progress with technology in the UK. So I just showed you pictures of what really we have technology-wise. So we have the flash and continuous glucose meters. So the picture on the left is a picture that we see readout of one of the Freestyle Libra. And I think it's actually really useful because you can have a quick idea about someone's control when you look at the report of the continuous glucose meters. These are the things that people have in their arms and they just flash it, or it continuously provides data to the readers. The other one that has been available for many years now is insulin pump, which is something provided only for those with type 1 diabetes who either have got poor control, so the HbA1c is out of target, or if they have issues with unawareness, so hypoglycemia unawareness. And again, very new kit on the block is the hybrid closed loop therapy, which is coming out really kind of now. It's still not available in most of the services because it's been only really discussed 2 weeks ago. But I think it will really transform what we do because this is a combination of the pump, the continuous glucose meter, and a clever machine which continuously reads and understands the glucose reading transmitted to the pump and essentially automatically alters the rate at which the insulin is infused. The reason why it's called hybrid is that the user still has to give information about how much glucose or carbohydrate and when they eat. So the kind of the food information is still not there, but actually in between the food, it automatically reads from the CGM and alters the rate of delivery. So again, things that really useful to know of what's out there, because you are likely to see patients with one of these devices. Now, something that I have struggled with when I was more junior doctor was really knowing all the different insulins. And I think that, there are so many out there and new ones are coming out all the time. And in a way, it's probably impossible to always remember all of them. But I think the really important thing to do is when you have an insulin is to try and understand what kind of insulin it is. So whether it is a short acting, whether it's medium or mixed or long acting, because that will really affect what sort of profile and effect it will have on the blood sugars on the patient. So I have just summarized some of the insulins so for your awareness. So we've got the rapid and short-acting insulins. So the ones you're very likely to see a patient using, things like Petra, TrueRapid, NovoRapid, and the fast version of NovoRapid, Fiasp, Lamju, or Humalog. Now we've got some of the older ones, which are not as rapid, so they're short, but they last longer, up to 8 hours, are the ones used in things like fixed rate or insulin infusions, for example, Actrapid. So Actrapid is the one that, at least in our trust, we put into the insulin infusion if someone needs fixed rate or variable rate. Then you've got your mixed insulin. So they are often used in patients who, for example, patients with type 2 diabetes who need multiple injections, but actually have fairly stable meal patterns. So you don't need to give them 4 injections with a basal bolus. You can give them Novomix or a mixed insulin. So examples would be Novomix, Humalog, or Humulin M3. So again, in our trust, we use Humulin M3 for those who are on NG feeding. And then you've got your basal, so the long-acting insulins. We've had quite a lot of relatively new ones over the last few years. So the older ones, Lantus and Levemir, and then there was a change to what we call the ultra long-acting insulin. So from Lantus, you got Toujeo, from Levemir, you got Tresiba. So these are the really, would say, truly more than 24-hour acting. So for example, with Tresiba, you can have a duration up to 42 hours. And then you've got your human-like insulin. So you've got the Isovane insulin or Humulin I. And something to be aware of, because it's a medication that contains insulin as well as other medication, which again became available probably about 5 to 7 years ago, is two. So it's Soliqua and Zultafy. Number one, I can never pronounce it, but it's just good to know that these have got long-acting insulins in them. Because what I encountered, for example, when I was on call in ED as a first-on medical registrar, is that often these medications are not stocked that easily. And so the important thing to do in those settings is to actually understand how much of the long-acting insulin person takes when they are on this mixture of medication. So, for example, with the Soliqua, it's insulin glargine, and one dose step is 1 unit of the insulin. So for people who are admitted to hospital who really need something, it's important just to give them equivalent dose of the long-acting insulin. And with the Zultafy, it's a mixture of insulin degludec and liraglutide. So finally getting to really the exciting bit with the diabetes at the front door. So a little bit of information about how often it happens. Well, actually, we know that nearly 1 in 5 patients in our hospitals have diabetes. We also know that most of the patients who have diabetes present to our A&Es as emergency, but actually it's an emergency related to something else than diabetes. The specific diabetes emergency account only for about 8% of admissions. And the reasons why they get admitted for the diabetes-specific emergency are very much the ones that we will discuss today. So these are the things like foot ulceration and sepsis from that, hypoglycemia, hyperglycemia, diabetic ketoacidosis, and hyperosmolar hyperglycemic state. So we'll start with the first case, something I'm sure that you see on nearly a daily basis. So we've got a 75-year-old lady who is non-type 1 diabetic. She has got control of 65 HbA1c, so not brilliant, but not too bad. She's using Libre 2, and she lives with her husband. we already know that she has got reduced hypo awareness. So that means that she doesn't have the normal warning signs that the hypo is coming, which means that actually they can come quite quickly, and so she can struggle to correct it. And already she was on the waiting list for insulin pump. So what happened is that she was found by her husband collapsed, wedged against the radiator with very low GCS. So ambulance was called and found that actually she had a very severe hypo, 1.5, and she was treated immediately with glucagon because she didn't have IV access. She managed to recover quite nicely, and then when she was back to normal GCS, she had oral carbohydrate. But she was taken to ED mainly because of the fact that she had to be given the glucagon, and we know that already she has got reduced hypo awareness, so she is very high risk of having hypos. And really what happened is that she had to be admitted and stay in the hospital until she received the insulin pump. By the way, some of the cases are all made up, but they are based, and I was inspired by people who are actually so. So hypoglycemia is very, very common. So it accounts up to nearly 15% of hospital admissions. It doesn't happen to everyone with diabetes. It mainly affects those who are on the treatment, which is likely to cause hypos. And we know it's insulin or the sulfonylurea group. So from the SU group, the common ones are gliclazide. Slightly less common these days are glimepiride. We can also experience it with some of the postprandial regulators, which are not used that often, but I still see some of them in my clinic, so something like repaglanide. We would say that the hypo is mild if it's self-treated and severe if it required third-party assistance. It's a good saying that to the patient that 4 is the floor, so they remember that 4 is the value that really we worry about with the hypo. Symptoms may vary, and I still remember when I was a medical student that I saw someone in D who everyone thought had a stroke, but actually didn't check their sugar and was profoundly hypoglycemic, and that really stuck with me that actually hypoglycemia can be a brilliant stroke mimic. So, you know, some of the symptoms, neurological deficits, and up to even seizures and coma. The worrying thing with the hypo is that if the hypo is prolonged, it can cause damage to the brain, which is permanent. As we are aware, the typical symptoms of hypo can be scored by the Edinburgh Hypoglycemia Scale. So the autonomic symptoms they start with is people feel really hungry, they are shaking, sweating, they have palpitations. And then if nothing really is done, the neuroglycopenic symptoms kick in. So they'll be a little bit confused, incoordinated, they'll have troubles speaking, eventually become drowsy. And then if it progresses, they will become unconscious. And the other very non-specific symptoms are feeling headache, nausea, generally unwell with malaise. So when we see someone with hypo, it's absolutely important after we treat the hypo to get to the bottom of what caused the hypo, so to know the risk factors for hypoglycemia. So really common ones I've grouped into 3 categories, so the medical, lifestyle, food-related, and endocrine problems. And a lot of these guidelines and information are taken from our joint British Clinical Diabetologist guidelines. So the medical reasons, one of them was why really our patient became really unwell was impaired awareness of hypoglycemia. And it's actually quite common in our group of patients with type 1 who have had diabetes for a very long time. Other problems with medical are those who have hepatic dysfunction, if they're really unwell with sepsis, or if you have cognitive dysfunction. And for example, people who have dementia and don't have anyone to help them administer their insulins, they're much more prone to essentially administer wrong doses or many, many times, and as a result, end up with hypo. We also worry about those who have got lipohypertrophy, so that's why we often check insulin injection sites to see if there is any fatty bumps, because if they inject into those areas, it will impair the absorption of the insulin, which means that actually they could get a staggered dose of insulin at once if it's not absorbed properly the first time around. From the lifestyle and food category, it's probably quite obvious, because obviously if we increase our exercise and decrease what we eat or the carbohydrates we eat, we're much more prone to get hypo. In hospital, this is very common. I see patients who just don't like the hospital food, they don't want to eat it, but they still get the same units of insulin because it's prescribed on their cardiacs, and they end up having hypos later on in the middle of the night. We also worry about those who don't absorb their food properly. So if they have had bariatric surgery or in any other way, impairment of their kind of transit through the GI tract. And then there is a subgroup of patients really with endocrine problems that have hypos because they have impairment of some of the contrarregulatory mechanisms. So, for example, those who have Addison's disease, growth hormone deficiency, hypopituitarism or hypopituitarism. So this is probably quite a small category of people who develop hypo, but it's important when we have unexplained hypo to actually look out for other things rather than just diabetes. So this is a guideline taken from the British clinical diabetologist, and it's a busy slide, really, really busy slide. So what I'm going to do, and what I did is actually I just provided a simplified version. So essentially, the treatment of hypo will be depending on what is the state of the patient. So are they awake? Are they conscious? Was their GCS? Can they swallow? Can they take things normally or not? So going back to this slide, really, I just like the coloring. So if you see that the mild category, mild is those who can take carbohydrate, because the key is after you do your A2E approach is to make sure that they have 15 to 20 grams of carbs. The treatment recommended is either dextrosol tablets, so you've got 5 to 7 dextrosol tablets, or 4 to 5 glucotabs, or up to 200 ml of fruit juice. In the past, Lucozade was recommended. But actually, we have to be really cautious with Lucozade because it doesn't contain the same amount of sugar anymore because of the sugar tax. So that's why it really is not recommended anymore, because we can't provide the up to 20 grams of carbs with Glucosade. And the important thing is, after we treat it, we check 10 to 15 minutes of blood sugar to make sure that it's gone back normal. And going really back to this, the simplified version, if we have someone who can't take, let's say, dextrosol tablets, but actually is conscious enough to have a bit of a gel squeezed, we can give 2 tubes of 40% glucose gels, and that is squeezed between the teeth and the gums. And if we have obviously the most emergency severe situation when we have someone who can't take anything orally, it's not safe because of an airway problem, we have option either, if we have IV access, to give them either 100 ml of 20% dextrose or 200 ml of 10% dextrose over 15 minutes. In the past, it used to be higher percentages, but it's been moved now. And the reason being is that, when in the past it was something like 50% dextrose, it was really not good for the veins. It was quite toxic. So we are now using small percentages in a way, but still get that 20 grams of the glucose. The very extreme is when we don't have IV access. Obviously, what we can do is we can use glucagon, so 1 milligram glucagon IM. The important thing to know with the glucagon is it might not work so well in those who don't have enough glycogen stores in their liver. So, for example, those who are very undernourished, so very, very low BMIs, or people who have very severe liver disease, they will just not have the glycogen there in the first place to be able to create the glucose de novo. So one of the things that would be really good to talk about is actually who to admit and who not to admit with hypo, because it is very common. And I think it's really important to say, even from the society states that not everyone that is seen for hypo will need hospital admission. And I think it's important to say that it's very much every individual is different, but we need to think of who are individuals at risk of having a severe hypo and who need the admissions. So when we see someone with hypo that we've treated, we need to always review what caused the hypo event. So when I was talking about the risk factors, we need to go through actually what was the precipitating cause for the hypo and have some awareness of what is their diabetes control like. So have they had a HbA1c in the last 3 months? If they've had recurrent hypos, we know that this is a very severe risk factor for having another severe hypo. So actually, if someone with recurrent hypos, I would have very much a threshold to bring them to be seen by the diabetes team. The other cautious thing is the use of sulfonylureas in people who are old. We know that this is not a very good idea because they are very, very prone to hypos. And the problem with SUs is that they can have a prolonged hypo. And so for those reasons, patients who are on SUs and are old and frail should be taken to hospital. The other thing to note is actually sometimes we need to make adjustments to the medication. And so if in doubt, and especially if it's possible in a day time, it's just good to speak to the diabetes team. And I spoke to our colleagues in my hospital, diabetes specialist nurses, and they often get calls either for patients or other healthcare professionals. So they are available for advice if it needs to be. This is just a second kind of continuation from the recommendation by the Clinical Diabetology Society, is that those who have got type 1 or who are insulin treated with type 2, who are otherwise well and actually can manage their diabetes themselves, don't need to come to hospital, but they need to have some safety netting, and they need to have some information provision of how to adjust their insulins and what to do in case of another hypo. The other thing to say is that they need to have some safety netting for the normal diabetes team. So either book them for a review with the diabetes team, or I'll let them know that they need to contact their team and check that they have got a number for them to contact them on. Importantly, and obviously those people, and a lot of them will be driving, who are driving, they need to be provided information about what to do with severe hypo, and the fact that they need to inform DVLA. People who have got other comorbidities or even just live alone, they will be much higher risk of having a hypo. So those kind of people should be reviewed in a hospital. And again, the other thing that the guidelines say is that if in any doubt what to do with the patient and whether we need to discontinue the medication, it needs to be seen by the diabetes team. I haven't found any obvious guidelines for the ambulance crews, but when I was doing my search, I found some good practice from various centres. So this is an example of a good practice that I actually found from East Midlands, because it states very nicely a recommendation of who are the people who really should be admitted or taken to hospital when they've had a hypo. And I think it is very much in line with what the JBDS guidelines are saying. So those who are older and live alone, those who are taking SU, so the sulfonylureas. If they are not known to have diabetes, and this is their first episode, again, this could be a presentation of, for example, someone who has got totally different issue, if they have maybe problem with their pituitary gland. And actually, so for that reason, they should really be reviewed. If they are not responding to treatment, or those who have had to have a glucagon treatment because they would indicate that there was much more severe hypo, again, should be taken for review in hospital. If they have any complications, if they're unwell with infection, if they are renal patients, again, those kind of patients who are unwell should be taken. So on the right, you probably can't read the writing, but I just want to show an example of a nice flow chart, because actually it shows the really good safety netting of what happens to those who have been treated by ambulance and actually have been deemed to be low risk, who didn't need admission, but it provides really clearly the pathway of how to get the patient seen by the normal diabetic team very much either the next working day or in a very next future or close future, because that is, I think, really good to have the safety netting for the patients. And I think that probably each region will have something different. But again, this is taken from the East Midlands. So I was following what's happening on Twitter before the talk, and I found that someone asked, what about insulin overdose? So I initially didn't include it, but I thought, okay, that's a really good point. Let's include it. So we'll talk about special situation of insulin and sulfonylurea overdoses. So I split it into the insulin and the sulfonylurea part. So for the insulin, the important thing to know is if this was intentional or accidental, because if something is intentional, it's much more serious and it's much more likely that they took a very, very high dose. So those kind of people should always be brought to ED. With the accidental, it's not a rule of thumb, but a lot of things have to be considered for those who have taken the insulin accidentally. The things to consider is what type of insulin they took. So whether it was long-acting, mixed, or short-acting. We also need to know what is a normal testing method. So for example, are they just doing finger prick, or are they doing continuous glucose meter? Because for those people who are using CGM, you've got the extra safety netting that CGM provide alarms. So actually, you know that something will alarm the patient when the sugar is coming down. The other question is, are the people able to correct the hypo? So do they have the hypo treatment next to hand? Do they know that they need to monitor the sugars very closely? Do they live alone, or do they live with someone? Are they able to actually do it? Do they have any cognitive problems? Are they frail? And then if all is good and they are able to self-manage, if they have developed the hypo and are actually struggling to correct it, and it keeps happening again, obviously they need to come in and have it treated, because they might need continuous intravenous dextrose infusion. And so for those who feel actually maybe they are able to manage it on their own at home, they also need to be safety netted and told either in a day they can contact the diabetes team, or at night, depending on the severity, they can reach the ambulance again. So going to now the sulfonylureas, which obviously is slightly more worrying, and I split it into intentional and unintentional. So the ones who have taken intentional overdose of sulfonylureas, after we do our normal A to E, we need to think whether it's been more or less than 2 hours, because if it's been less than 2 hours since they took it, we can give them activated charcoal if the airway is safe. And then based on whether we have IV access or not, we would treat either with glucagon or dextrose based on IV access. But a real interesting thing with the sulfonylurea overdose is that the treatment after IV dextrose, if it's not working, is IV octreotide. So this is very unique. It doesn't happen very often at all, but actually at some point in their career, a diabetes doctor is likely to see at least one of sulfonylureas overdose. And so the IV octreotide is the first line for people with SU overdose after dextrose. And this is sadly not so exciting in terms of color slide, but I took it directly from a paper that was from the British Journal of Clinical Pharmacology in 2016, which again summarizes really nicely on what to do with either sulfonylurea or insulin exposure. And it's actually similar in terms of what to do. So for the sulfonylurea overdose, it again talks about the octreotide. For the insulin, depending on the blood sugar level, it obviously states to give IV dextrose. What I think is really useful, and I'll go on to the next slide, is actually some of the points of who are the people that we worry about and who are the people who potentially might be okay. So it states that all kids, so it's all pediatric population, and those who do not have diabetes and who unintentionally ingest SU, or those who take it on purpose, and also those who take the injection of insulin on purpose, they all need to be taken to hospital. Then the category of those who have taken insulin a little bit extra, not knowingly, so it was a mistake, unintentional, they can be monitored at home. However, if they become symptomatic and the hypos are persistent, so they can't get on top of it because they keep getting hypo despite treatment, or if they can't monitor it, they really need to be brought to hospital also. The thing to do in hospital, if we're finding they're having hypos, is to obviously give them intravenous dextrose infusion. But importantly, even after the dextrose infusion stop, we need to monitor them after 12 hours. So that's something to keep in mind, that we can't just stop the dextrose and send them on their way. No, we have to actually monitor them, because we are looking for the prolonged action of these agents to check they are not having recurrent hypos. So I think this was very long hypo bit, but I think it was really important, because actually this is something that is happening very often and is likely to be the thing that actually you will see, especially from the front line and paramedics, and not all of them will need to be admitted. So jumping straight, because I'm aware of time, to case 2. So we have got 28-year-old lady who is not known to have diabetes, and she's coming sick with diarrhea, vomiting. She's hypotensive. And the first thing we know in an ambulance is that the blood sugars are 30, the ketones are high, 4.6. When it comes to ED, after A to E has a gas, which shows that she's acidotic also, and she's hypotensive. Perhaps unsurprisingly, she is also hyponatremic. So this is something that we see quite commonly. She is treated for severe DKA, and ITU is being brought just for review because of the hypotension acidosis. Just on this slide with the sodium, I wanted to explain, because often this causes some confusion, but actually, if your sugar is really high, it can cause what we call pseudo-hyponatremia. So actually, it's not true reflection of the sodium, it's low because the blood sugar is really high. So it corrects very nicely as the person's sugar starts climbing down. So DKA, I find DKA actually always quite nicely straightforward because diagnostic criteria are also very straightforward. So it's in someone who has good sugars above 11, who have either capillary ketones 3 and above, or urine ketones 2 pluses, and who is acidotic, so pH less than 7.3 or bicarb less than 15. These slides are taken directly from the DKA guideline from the JBDS. And again, it's really nicely straightforward because they state very obviously of who are the people who need to be reviewed by ITU. And the reason being is that the DKA is more severe. So for example, if they are very acidotic, so if their pH is less than 7.0, or those who are already very unwell. So for example, if they are a dialysis patient, if they are a heart failure patient, if they are pregnant or elderly. So again, really nice. And I would say, something that I wouldn't really expect anyone to know by heart, but it's very easy to find out if they just Google JBDS DKA guideline to look for the management. And again, very clear statement of what needs to happen for these people in the first hour. So this is probably something that happens in ED, in resus. So me as kind of a medical registrar, I would get to these people probably after the first hour. So all of this really gets done by our ED clinicians. So the first thing is really after A to E is to give them, cannulate them and give them some fluid because they are very, very dry. Given the fact that they have been weeing loads because of the osmotic diuresis, they are extremely dry. And the second thing after we start with saline is to put them on a fixed rate insulin infusion, with the rate is based on their weight, so on kilo, so 0.1 units per kilo per hour. And then essentially assess to see what caused the decay. So the full set of investigations, chest X-ray, and all things that we normally do in someone who we don't know what caused the decay, so infection or ECG for any heart abnormalities. The next thing to do is really to establish how we're going to monitor them. So we need hourly blood glucose, we need hourly ketones. We also need 2 hourly VBGs because we need to monitor to begin with what is the bicarb potassium. And then after that, we need 4 hourly USNE. So these people really are in resus and they have got a high requirement in terms of the monitoring. The fluids, it's something that every now and then causes some confusion because this is the only situation where you can infuse potassium quicker peripherally than in other situations. So normally, if you have a normal peripheral line, we can't give potassium quicker than 4 hours. So normally it would be 1 liter, 40 millimoles over 4 hours is the quickest we can give it. But DKA is the only time when we can give the second back, which is the liter of normal saline over 2 hours. And that liter, if the potassium is between 3.5 and 5.5, will be with 40 mL of potassium. So it's caused a lot of questions before, but yes, this is absolutely as per the guidelines. So this is the only time when we can give it quicker. And the reason being is because we are giving them intravenous insulin, which will drive the potassium into the cells. So it's really important to replace them. Otherwise, they will become hypokalemic. And actually, this is one of the things that if they are indeed hypokalemic, if the potassium is less than 3.5, they need a review by the ITU because they might then need the replacement of potassium quicker than per this regime, which means that they would then need a central line for quicker administration. And then it talks very nicely about what to do kind of hour to hour. So after we have started on a fixed rate and the fluids, we just do the monitoring, which unfortunately for the staff is very frequent. So it's really busy, but actually it's really important. And then when the blood sugar drops to less than 14, we also start 10% glucose. And often it is concurrent with already running saline, again, because they are so dehydrated. Thing to note, and doesn't happen very often, is actually those who are newly diagnosed with type 1, or we think this is new diagnosis with type 1, they should be given a long-acting basal insulin. So this will help to get them out of DKA quicker. It's at a dose of 0.25 units per kilo, and it really gets them on the way because a lot of the times when I come to see the patients, they haven't had their long-acting insulin. And actually, importantly, those who are non-type 1s, they should continue their normal basal-acting insulin. So you should continue their Lantus or Toujeo, Tresiba, always, even though they are on a fixed rate. And they need Clexane prophylactically because they are so dry that they are at high risk of having a VT event. And again, this guideline just nicely show what to do after the first 6 hours. So probably not much that maybe you will be involved with as a very emergency healthcare workers, but something probably that happens then for when they are admitted on the medics. Resolution of DKA is when the ketones are less than 0.6 and the pH is above 7.3. So, and then within the first day, really, we're trying to get them from the fixed rate to either a variable rate if they are not able to eat and drink, or if they are actually able to eat and drink, we can go straight from the fixed rate to the subcut insulin. It's been more tricky with those who haven't been diagnosed yet, because obviously we don't know how many units they'll need, but it will be based on how many units they needed over the time when they were on the fixed rate, and as well as what's their weight. Because we know for newly diagnosed people, especially if they are younger and the BMI is lower, is they could be quite sensitive to insulin. So those who probably start on a lower side and be increasing with caution. So next case, so really going through it very quickly, 45-year-old guy who has got type 2 diabetes, and he is also coming with DNV, so something must have been going around because everyone's getting DNV, and he's dehydrated. He takes metformin, dapagliflozin, and sitagliptin. So for this one, the presentation shows that he is very acidotic, he's ketotic, but he doesn't have high blood sugar. So what's going on? His blood sugar is only 10. So this is something that's becoming more and more frequent, probably in the last 4 or 5 years, because more and more people are on the newer type of medication, the SGLT2 inhibitors. So he's diagnosed with euglycemic ketoacidosis, as well as AKI, he's very dehydrated, and he started on a fixed rate, as well as IV fluids, and all his meds are reviewed. So EUDK, so euglycemic or normoglycemic diabetic ketoacidosis, is treated exactly the same way as a normal hyperglycemic DKA. So you need your fixed rate, but what we also need to do is you need to start on a 10% dextrose straight away because their blood sugar is lower than 14. By definition, to be EUDK, it has to be less than 11. So because it's less than 11, you need to give them dextrose also. And obviously then what is a bit more tricky is what to do on someone who has got IV insulin running, but also doesn't have that much high blood sugar. So we need to be really monitoring it frequently and seeing if we need to reduce the fixed rate to half fixed rate, so from 0.1 to 0.05, and really monitor and giving the dextrose to make sure we don't give them hypo. So I wanted to include a slide about this because this is something I did my PhD on. So I feel really excited by SGLT2 inhibitors. So this is an example of epinephrine. So you can see the glomerulus there, and you can see various labels, but I wanted to show really where the SGLT2 inhibitors are. So you can see them on a picture. So these inhibitors, so sodium glucosylate inhibitors, will block the transporter that is found there in the picture. And what it means is that the person will excrete more glucose and more sodium. And obviously that's a good thing because that's how it lowers the blood sugar. And what it means is that person who takes SGLT2 inhibitors will lose up to 120 grams of glucose per day, which also means that obviously they are losing calories. So that's another reason why patients on SGLT2 inhibitors will also have some weight loss because they are weighing out sugar. But the reason why we worry about this in people who are really unwell and dehydrated is that if you are weaning out sweet wee, you're going to also wee more out of it. So you are going to have slightly higher urinary output. And already then you are more predisposed to dehydration. And suddenly, if you are really, really unwell with, let's say, profound vomiting, you're going to be really dry. And this is going to be dehydrating even more. So then what happens is even though your blood sugar is okay, you're going to start to develop AKI and as a result, ketosis and acidosis. And so this is really what happens in those people who are on SGLT2 inhibitors who become really unwell and who already have what we say as insulin deficiency. So it's much more likely in those who are, let's say, type 2 diabetes patients who need insulin, or who are likely to start using insulin because their pancreas is nearly run out of insulin. But that's why we tell our patients who are started on this medication sick day rules. So anyone who gets unwell with DNV, who is on SGLT2s, we all say, please pause it when you're unwell until you become able to drink normally. So case number 4, we've got another chap with type 2 diabetes, slightly better control, 57, but annoyingly not on any treatment at all. And what happens is that he collapses at home and wife calls ambulance. He's taken to ED and is found to be very hyperglycemic. He's found to have some ketones, but extremely dry. So his sodium is 160 urea 15. Also found to have consolidation and treated for it with antibiotics. But the really important thing from the diabetes point of view is that he has got another diabetic emergency. So he's coming with the overlap of what we call a DKA/HHS. So he has got hyperosmolar hypoglycemic state with some ketosis, which means that actually there's an overlap with the DKA. So I always found the treatment pathway for HHS extremely complicated. And I would say the first thing that is really important to do is always consider in those who have got high sodium and high blood sugar. So if we've got someone who comes with blood sugars above 30, who have got osmolality above 320, and who is very dry and hypovolemic, who doesn't have any ketones or not significant ketones or acidosis, we need to consider a diagnosis by HHS. The most important thing is to replace fluids, so rehydrate people, because they are extremely dry, given that they have been in very high blood sugar levels for quite some time and have been essentially having high kind of osmotic diuresis. And the key there is to aim for a drop in the osmolality between 3 and 8 per hour. And keeping the sugars nicely controlled between 10 and 15 and prevent complications that come from this state of HHS. Now, this is a slide that was provided by the JBDS Society and the guidelines, and it's supposed to be a summary, nice and easy slide. And I think it's still extremely busy slide. And I will just talk about some of the key things because the ones that I feel are really important. So with those patients coming in, obviously we need to do the history as usual and assess what is likely to have caused this HHS. And really commonly, it will be some kind of infection, sepsis. It would be that they are not treated properly for the diabetes or if had vascular event. And the other thing that is really key is just consider calculating your osmolality, or do calculate osmolality before your plasma or your lab osmolality is back, because it will take ages. So it will not be back for at least kind of 4 to 6 hours. So in the meantime, you will have all the things we need from a VBG so we can actually calculate osmolality. So 2 sodiums plus glucose. And then when you've got urea back, also add urea into the equation and to see, is it more than 320? Yes. Okay. Well, you've got your answer. And then we need to monitor it hourly for the first 6 hours, because we are very much keen in measuring the reduction in the osmolality for those patients. And again, it's something that doesn't get done very often, partly because it's probably quite difficult to do hourly VBGs on these patients, but really important for their overall kind of prognosis and how they are treated. And the key thing with those patients is they are really dry, they need to be dehydrated. So give them plenty of normal saline, so 1 liter over 1 hour. And then based on the fact whether they have got ketones or not, whether they also need to have some fixed rate. So we would only start a fixed rate insulin infusion straight away if they have got ketones. So if they have more than 1 and less than 3 ketones, we know that they will need a little bit of insulin help to get the ketones out of the system, so they need to be started on a fixed rate. Again, this is continuation of the guideline of the summary slide. Again, very complicated. I'm sorry about that, but this is probably as easy as it gets when it comes to summary of this guideline. Is a nice overview of what to do when the osmolality isn't really getting better. So if we are dropping by the recommended 3 to 8 and we are not getting them into fluid overload, good times we can just continue with the normal saline, no problem. What we also know is actually initially when the osmolality is dropping, the sodium will be increasing to begin with. But provided they are dropping the osmolality and they are not getting overload, and we think they are getting the right amount of fluid, we just continue as usual. We would only worry about it if we find that not only the sodium is increasing, but also the calculated osmolality is increasing. Because if we feel actually they are getting a right fluid balance and both the sodium osmolality is increasing, that's when we would have to switch them to half saline, so 0.45% saline. And then the second aspect, after we check the osmolality and sodium, is the glucose. So again, we need to monitor the fall in glucose to see it should really be falling at a rate of 5 per hour. If it's more than that, we might need to reduce the fixed rate if they're on fixed rate. And if it's less than that, we just need to check that they are getting adequate fluid balance, so they're getting enough of the fluids. So I think probably I will not really delve too much more into this because it is complicated and there is a really good guideline, but I guess the key line is they need hourly VBGs for the first 6 hours to check their osmolality. Okay, so this is last case. So 56-year-old chap, again with type 2 diabetes, not good control at all, HbA1c 78. He essentially doesn't have any sensation in his feet, and he was trying to wash one of his foot because he felt something was on it. He submerged it in a bucket of too much of a hot water. He didn't feel it was hot, and now he's coming in with really monkey foot. So he essentially was found less responsive, hypotensive, and very much looking septic from a foot ulcer. When he's seen, the pulses are not palpable, so we know he's got also some vascular supply issues, and he's got a pretty nasty ulcer on a left big toe, which actually looks very cellulitic. There is erythema and extends up to the midfoot. So we are now worried also about potential infection in the bone. So what happens is that after all the bloods and antibiotics, he also gets X-ray to show that there isn't any osteomyelitis. And he's treated initially with broad spectrum antibiotics, and then when we managed to get the culture back, actually put into the more specific antibiotics. Unfortunately, after several days in the hospital, because he's not responding and he has complications, he ended up having amputation. So the diabetic foot, something that, well, just today in the afternoon, I did a diabetic foot clinic. So it's something that is really common and really unfortunately, in UK every year we have 9,000 amputations. It can present in various ways, the diabetic foot. So it can have a wet or dry gangrene, you can have critical limb ischemia, you can have Charcot neuropathy or ulceration abscess, so sepsis. There is a good guideline in how to classify the degree of severity of diabetic foot infection. So it's something we took from the American guidelines. So this is Infectious Disease Society of America, and to mild, moderate, severe. And I think it's quite nice because it helps really with judging who could be treated with oral antibiotics and who might have to be treated with intravenous antibiotics. I'm getting thumbs up. I'm guessing because it's nearly 1 hour. Before I progress to the last bit, which is about hyperglycemia, let me know because it's been quite intense. Would you like me to continue with the next, I think about 5 to 7 minutes? I wrap up. Okay, I'm getting thumbs up. Fantastic. All right, so I'll speed up, hopefully. Right. So on the diabetic foot, which individuals should be admitted, really, really important. So wet gangrene. So if someone's got wet gangrene, if they have ulceration and we can't feel their pulses, or limb ischemia, if there are fever, signs of sepsis, or if we think, gosh, this is going to be quite deep, bone infection. Really good guideline. So again, something you can just quickly look at. JBD's guideline, diabetes at the front door, really nicely shows you what to do with those coming to ED with the diabetic foot problem. So I will not go through it because it's something maybe you can have a look at your own time. Now, the last bit really, and I think it's still quite relevant, is what to do with those people who come in who are not in DKA, not in HHS, and they are just coming with a really high blood sugars. So, and this is probably for more of my ED colleagues to see, do they need admission, do they not need admission? So the question really is, after we rule out that there isn't any of the emergencies, we need to check whether they need admission for something else than the diabetes. If they don't need admission for anything else, we then need to ask the question, how bad is this hyperglycemia and are they really osmotic and symptomatic from it? And could there be a chance that this is a new presentation of type 1? So for the likely type 1, I would say, oh, this actually needs to be reviewed or discussed with the diabetes team. And really those kind of people who are coming with hypoglycemia and we think they are symptomatic type 1, we should be starting long-acting insulin and getting them diabetes review. If we think, well, this is not likely type 1, they are probably type 2, do they need to be started on something to bring their sugars quite quickly? And that would be insulin or sulfonylurea. So if they have osmotic symptoms, they are peeing low, they are thirsty. If their CBG is above 18, if they have got some ketones, so above 0.6, but not acidotic, then we need to really start giving them something, so either insulin or sulfonylurea. So I found a nice example guideline from Leicester. So this is something for those who think, well, they might have type 2 and they are new presentation. So the unwell type, really easy, because if they are unwell and need admission anyway, well, it's very easy because we then put them on variable rate if they can't eat and drink, and we address the issue why they came in the first place. If they are well and they have got small amount of ketones, they can be started on traditional medication, so either the metformin or nagliptin. If they have got some ketones, we think actually the sugars are high, we would need to think about the glycoside, the SUs, and the insulin. I would say the key point there is that if for those who are mildly ketotic, so between 0.6 and 1.5, ideally we would get the diabetes team involved so they can actually safety net them and see them quite promptly. For those who have likely type 1, it's slightly more complicated because they will always need a long-acting insulin, because if we think this person has type 1, eventually they need basic bolus regime, so we need to start them with the long-acting insulin. And the short-acting insulin will depend very much based on what's their ketones. So again, in those who are unwell, it probably makes our decision-making process a bit easier because we know for sure those need to be admitted. Those who are well, I think it's really important to see what their ketones are. So if you follow this paradigm, as if the ketones are between 0.6 or 1.5, or even the ones who are up to 3, who are well, we can try to see, do they improve with rehydration, and do they improve with a little bit of PRN insulin? Because if they do and they are falling, that's good news, because that means that they are out of the danger zone, but they now just need to have some plan going forward. And every hospital is going to be different in terms of how these new presentation of patients need to be seen. So we are actually working on a guideline in our hospital, and it will be that those who we feel are likely new type 1 will always want to see before discharging them, for the purpose of safety netting and making sure they know what to do and they know how to measure. And this is my before the last slide. So one last before the last. What to do based on the sugar levels. So often we get asked, well, how much PRN insulin we give and why. So I would say there's a rule of thumb. 1 unit of Novorapid will bring down the sugar by 3. It will obviously be different in someone who is very insulin naive and sensitive, or in that person who has got extreme insulin resistance. But this is very much just the average. 1 unit of insulin brings it by 3. So for that reason, the rule of thumb is if their sugar are between 18 and 25, we can give them 4 units of Novorapid and check in 2 hours. If they are above 25, we can try 6 units of Novorapid and again check in 2 hours. But this is something that obviously can be useful when they're needy, but that needs to be followed up for them with a plan of what happens on a regular basis on a basic bolus. Right, I think I made it just before the hour. So in the summary, we have covered lots and lots, but really I wanted to show hypoglycemia and what to do in special situations with overdoses. We talk about DKA. We talk about special one like EU DKA. We talk about type 2 diabetes coming in with a hyperglycemic, hyperosmolar state. We talk about diabetic ulcers, and then we end up talking speedily about what to do with the cases of hypoglycemia in those who are not in some of the emergency situations. So that's it from me.